Cardiovascular system infection. This is the second part of cardiovascular system infection, which will be about rheumatic fever. First part was in the previous lecture, which was about endocarditis. Then we will talk about rheumatic fever. Rheumatic fever. Our ILOs will be about, by the end of these lectures, we must be able to first identify the etiology, pathogenesis, clinical presentation, laboratory diagnosis of rheumatic fever. Second, outline treatment and preventive measures of rheumatic fever. Rheumatic fever is one of the most common complications of post-streptococcal infection. It is a serious post-streptococcal immunological complication. It's usually following streptococcal infection in the throat 2 to 3 weeks later on, leading to rheumatic fever with permanent damage of the heart valve. It is usually preceded by types of streptococci, which is Streptococcus pyogenes. It is one of the beta hemolytic streptococci. The group A beta hemolytic streptococci causes infection in the throat or respiratory tract. It is one of the major causes of acquired heart disease in young people throughout the world, especially in Egypt. So rheumatic fever is a complication of post-streptococcal infection in the throat or respiratory tract, which is not well treated and leading to rheumatic fever with permanent damage of the heart valve. We'll talk about some important characteristics of common positive agents. And we'll talk about it in short. We remember together that gram-positive classified either gram-positive cocci or bacilli. Cocci we classified into staphylococci and streptococci. This depends on the result of catalase test. Catalase positive is the staphylococcus and catalase negative is the streptococcus. From staphylococci can divide it into two types according to coagulase, which is coagulase positive Staphylococcus aureus or coagulase negative Staphylococcus epidermidis and Staphylococcus abscessus. Catalase negative cocci is the streptococcal group, which can be divided also according to its effect on the blood, hemolytic effect on the blood, which may be cause a complete hemolysis like Streptococcus pyogenes, group A streptococci, group B streptococci, streptogalaxia. It may cause alpha hemolysis or partial hemolysis like streptoviridans and streptopneumoniae, or maybe non-hemolytic like enterococcus. So flow chart, remember together about gram-positive cocci. Gram-positive cocci by catalase test, either it is positive or negative. If it is positive, then it is a Staphylococcus species. Negative, then it is a Streptococcus species. Staphylococcus species will do coagulase test. If it is positive, it is a Staphylococcus aureus. and if it is negative, it is a coagulase negative Staphylococcus species, which may be Staph epidermidis or Staph subophytic. If catalysis is negative, it is a Streptococcus species. So it's grows on sheep blood agar. If it causes beta hemolysis, which is a complete hemolysis, it may be streptobiosis. Grows in presence of bacitracin. It is no sensitive, so it is streptobiosis, which is a group A streptococci. If it is gross occurs in the presence of bacitracin, so means it is a resistant another beta hemolytic streptococci. If it causes a partial or alpha hemolysis in the blood agar, can be may be Streptococcus pneumoniae or other alpha hemolytic streptococci. Can be differentiated by using Optochin test. If it is no sensitive, non-sensitive, so it is a strep pneumonia. If it is resistant, it is alpha hemolytic, other type of alpha hemolytic streptococci. Streptococci are classified by Lansfeld classification according to carbohydrate antigen into different groups. One of them is group A, Streptococci, which is group A beta hemolytic streptococci, for example, streptobiogenes. So, streptobiogenes are group A beta hemolytic streptococci. And according to surface M protein antigen, which is Graves classification, group A beta hemolytic streptococci can be further classified into more than 8 serotypes. So, group A beta hemolytic streptococci, streptobiogenes, can be classified by Graves classification into more than 8 serotypes. Virulence factor of streptobiogenes include cell-associated factor and enzyme and toxins. From cell-associated factors, the most important virulence factor is M protein, which has antiphagocytic activity. It acts by binding with some complement regulatory factor, which is present in the serum, resulting in masking of the bacterial surface by the host protein. Also from virulence factor, some enzymes and toxin. From them, the most important is streptolysin. These are hemolysin of two types. Hemolysis that's produced by beta hemolytic streptococci is hemolytically active only in the reduced state. From the two types, there is streptolysin O, streptolysin S. Streptolysin O is an oxygen labile and loses its activity in the presence of oxygen. So it is active in a reduced state. It is antigenic, means is that it induces antibody formation, which is anti-streptolysin. Also, it increases the beta hemolytic zone diameter of anaerobic culture. Streptolysin S, which is oxygen stable, but it is non-antigenic. It is responsible for the beta hemolytic zone around streptococcal colonies. Pathogenesis. Streptococci is a post-streptococcal immunological complication. It represents type of hypersensitivity response to streptococcal M protein. The disease results from production of antibodies. These antibodies against the M protein of streptobiogenes. The antibody cross-react with the heart, joint, and brain tissue. And inflammation occurs, resulting in carditis, arthritis, and chorea. That are the characteristic findings in this disease. Acute rheumatic fever occurs as a post-streptococcal sequence. So occurs post-streptococcal infection in the throat, with repeated attack of throat infection with streptococcus biogenes, leading to formation of antibodies against M protein. This antibody cross-react with epitopes, which is present in the heart myogenes and circular membrane protein, which leads to complement activation and inflammatory response. And at the end, it results in damage of the heart valve. Clinical presentations. Patients with rheumatic fever usually come with fever, malaise, non-suppurative migratory polyarthritis, rheumatic carditis, and rheumatic chorea. Rheumatic carditis results in a more or less permanent damage to the heart, which is the main virulent manifestation of rheumatic fever. Recurrence of rheumatic attacks is activated by repeated attacks of streptococcal infection. And with every attack, there is more cardiac damage, with increase in the severity of the disease. Patient may come with fever, with a history of sore throat, chorea, with involuntary movement of the extremes and face affecting speech, erythema, which is a red skin lesion starting on the trunk and spread peripherally, subcutaneous nodules with a small, non-tender swelling often covers the joints. Also, one of the main characteristics of clinical manifestation of rheumatic fever is polyarthritis, which is a tender, painful joint. It occurs in the elbow, knee, ankle, and wrist, with carditis manifestation, with carditis inflammation of all parts of the heart, mainly mitral valve. And in some cases, it may be associated with abdominal pain, which is very rare. Laboratory diagnosis. For diagnosis of a case of rheumatic fever, there is no single specific laboratory test which can confirm the diagnosis of acute rheumatic fever. But with evidence of post-streptococcal, group A post-streptococcal infection is an integral part of the Jones criteria of acute rheumatic fever diagnosis. Laboratory diagnosis of rheumatic fever. There is a specific test used for diagnosis of rheumatic fever, which is anti-streptolizin O titration test. It mainly depends on detection of antibodies against streptolizin O. It is a specific test used for detection of streptococcal antibodies directed against streptococcal lysin O, a hemolysis that is produced by beta hemolytic streptococci, and it is hemolytically active only in the reduced state. An elevation in the titer with proof of a previous streptococcal infection. It is usually more elevated after pharyngeal than skin infection. Anti-streptolizin O titer appears about 7 to 10 days and peaks is about 2 to 3 weeks. It's considered high if the figure is more than the baseline value present in the community. In endemic areas, the baseline of anti-streptolizin O titer could be 250 units or more, whereas in non-endemic area, it could be as low as 50 units. Increasing titer indicating a recent infection with group A beta hemolytic streptococci. Using two antibody titer, that is anti-streptolizin O combined with DNase B titer, increase the specificity of the diagnosis to about 90% or more. These two units primarily refer to the person who first done the test, which is in 1932. Acute anticovalence serum, if available, are helpful for proving a recent streptococcal infection. We must know that a relatively high titer are commonly encountered in the population with high rate of streptococcal infection. So different from area to another, which is endemic area or non-endemic area of rheumatic fever. Other non-specific tests used for diagnosis of rheumatic fever. These tests indicate a recent infection and tissue damage. They are non-specific tests. It does not mean that it's a proper diagnosis of rheumatic fever. It's positive in recent infection and in any tissue damage. They are useful in follow-up of acute phase reacting. These tests are erythrocyte sedimentation rate, ESR, and C-reactive protein, CRP. In acute phase reactant, including ESR and CRP, are usually elevated at the onset of acute rheumatic fever. They serve as a minor manifestation in Jones criteria. Both are non-specific tests, but they can be useful only during follow-up and in monitoring disease activity. Prophylaxis for a patient from rheumatic fever. We can use either long-acting penicillin, which is used as a chemoprophylaxis to avoid repeated attack of post-streptococcal rheumatic fever. In case of a penicillin allergy, we can use another type of drugs, which is erythromycin. This is used in case of penicillin allergy. Which one of the following best describe pathogenesis of rheumatic fever? A. An exotoxin produced by streptobiogenes that acts as a super antigen which damages cardiac muscle. B. An exotoxin produced by streptobiogenes that's AGP ribosylate, a G protein damaged joint tissue. C. An antibody to the capsular polysaccharides of Streptococcus biogenes cross-react with the joint tissue and damage it. D. An antibody to the M protein of Streptococcus biogenes which cross-react with the cardiac muscle and damage it. E. An endotoxin produced by Streptococcus biogenes and activate macrophage to release cytokines that damage cardiac muscle. True answer is D. which is an antibody which is formed against M protein of Streptococcus pyogenes and cross-react with the cardiac muscle and cause damage of it. Thank you.